Good day, everyone. Welcome to today's program of Learning Basic Arthroscopy series of lectures. Today we have a wonderful topic and a wonderful surgeon and clinician with us, Dr. Robert LaPrade. So, I'm Dr. Saseendar. I'm sure a knee arthroscopy surgeon from Apollo Hospital, Muscat. And along with me hosting the program is Dr. Srinivas Kambhampati. He is arthroscopy and arthroplasty surgeon from Sri Datri Center, Vijayawada. Along with us, we have Dr. Sundararajan and Dr. Bobby Anand. I kindly request Dr. Srinivas to introduce Dr. LaPrade.
Thank you, Sasi. Good evening, everybody, and welcome back. We have an eminent expert panel today, Dr. LaPrade and Mr. Bobby Anand. Mr. Anand has been with us before, and Dr. Sundararajan. It is indeed an honor and pleasure for me to introduce Dr. Robert LaPrade and my good friend, Mr. Bobby Anand. Dr. LaPrade needs no introduction to knee surgeons. He is working as a complex knee and sports medicine surgeon at the Crosstown Surgery Center, Egan Orthopedic Surgery Center, Fairview, Southdale Hospital, and Twin Cities Orthopedics in Minnesota. He did his undergraduation from Chicago, and his thesis during post-graduation was on the anatomy and diagnosis of posterolateral corner injuries. Dr. LaPrade is known as a specialized clinician scientist who has utilized his vast and comprehensive research on sports medicine injuries to improve patient care and invent new ways to treat knee problems. Many of the surgeries that he has devised have been performed worldwide and are recognized as a top level of care for many complex knee surgeries. As one of the world's most celebrated complex orthopedic knee sports surgeons, Dr. LaPrade has published more than 525 peer-reviewed scientific manuscripts, 125 book chapters, and has given over 1,000 professional presentations, symposia, and instructional course lectures, and mentored numerous fellows. He has received many awards for his research, including the OREF Clinical Research Award, which is considered a Nobel Prize for orthopedics. He is also the sole author of the only comprehensive textbook on posterolateral knee injuries. He is recognized as a pioneer in knee research, with many referrals from international and nationally recognized physicians due to his successful patient outcomes and his development of more effective surgical techniques for the reconstruction of complex knee injuries. Additionally, he has been involved in collaborations with basic scientists and physician scientists at many academic research institutions around the world. He currently serves on multiple editorial boards of orthopedic journals and is an adjunct professor at University of Minnesota. And he has been a member of research and scientific committees of major associations related to sports like ISACOS, ESCA, AOSSM, and AAOS. And he is on the editorial board of major journals like AJSM, KSSTA, and JKS. Mr. Bobby Anand is not a newcomer for us. He has appeared on multiple occasions on our talks. Thank you for giving us your time, Bobby. He will be joining us soon. He's a specialist knee surgeon based at Surrey and London in the UK. He's a joint director of surgery at Southwest London Elective Orthopedic Center, also known as Swelliok, the biggest joint replacement center in the UK. He treats many high-profile professional athletes from the sporting world, including footballers, hockey players, and martial arts experts. He's also leading robotic knee surgery in the local area. His research interests focus on ACL, MCL, return to sport, and patellar instability. He has served on numerous international committees over the last 6 years. Currently, he serves on the sports knee committee for SICOT. Welcome again, Dr. LaPrade and Bobby. Over to you, Sasi, to introduce Dr. Sundararajan and take the proceedings forward.
Thank you very much, Dr. Srinivas. Dr. LaPrade doesn't need any introduction. Thank you very much for joining us today. And let me introduce Dr. Sundararajan. He is consultant arthroscopy and sports medicine surgeon from Ganga Medical Center and Hospital, Coimbatore, India. He has done his fellowship in Flinders University and France, and with Dr. William van der Merwe in South Africa. He has also done foot and ankle fellowship at Duke University, USA. He is past president of the Indian Association of Sports Medicine and Indian Foot and Ankle Society. Currently secretary of the Indian Arthroscopy Society and president-elect of Tamil Nadu Arthroscopy Society. That's the state society. He is also the committee member at ISACO. Thank you very much, Dr. Sundararajan, for joining us to moderate the session. Over to Dr. LaPrade. Please go ahead with your talk, sir.
Thank you very much. Thank you for the kind introduction, and welcome from snowy Minnesota. It's morning here. So what I'd like to do is to go through my talk and review the history of how we looked at posterolateral corner injuries. And it's sort of like a story. So hopefully you can hear the story and how we developed this. A lot of the work was concurrent with our Norwegian colleagues and Lars Engebretsen at the University of Oslo. And I'll try to go through that. So I'll go through my talk.
Please.
So I was asked to speak about this anatomic-based reconstruction technique that we've developed, but also the general history on how we arrived at posterolateral corner injuries. And I think it's important to look at it is when I first started out in practice, when I went around and discussed with fellowship directors what was the hardest thing to treat at that point in time, it was pretty uniform that it was posterolateral corner injuries. I don't think we recognized articular cartilage as well back then in terms of its problems and how we've gone on to have issues with cartilage, but the posterolateral corner of the knee was an issue because there weren't any good quantitative anatomy studies. It was a diagnosis that was often missed and led to frequent causes of failed cruciate ligament reconstructions. Most of the surgeries were sling type procedures or repairs and casting, and rehabilitation was not well defined. And in general, there were really poor outcomes. The best studies were getting 60% successful outcomes, which when I went to college, that was a D. So in addition, the varus just wasn't being taken care of, and external rotation was, but sometimes it was being over-constrained. So it was a big problem. So we set about trying to address this and try to find a better way to treat these injuries. And the way that we do our research is we call it the research pyramid. And the posterolateral knee pyramid was the first study that we looked at this. So the base of the pyramid is to redefine anatomy based on quantitative studies, then to revisit the biomechanics based on these quantitative studies and look at better ways to objectively diagnose the pathology. Then we looked at anatomic reconstructions and looking at both the surgical approach and also trying to find a better way to develop something that would restore anatomy but not over-constrain the knee. And ultimately, the top of the pyramid has to be clinical outcomes. We have to see if these studies actually work. So I'll try to go through that in my talk and show what we did along the way. And we've since done this for PCLs and MCLs and some on ACLs. We're looking at biologics, meniscal root repairs, meniscal radial repairs. So that's how we try to develop our research program, is to go back to the basics, make sure we understand it thoroughly, and then go forward and ultimately look at clinical outcomes to see if what we've accomplished actually is successful in patients. So when we looked at it first, when we're looking at the base of the pyramid, we wanted to make sure we knew exactly what was going on in terms of the anatomy. And first off, the bony anatomy is important here. We found out through animal models why the posterolateral corner of the knee does not heal, whereas the MCL heals, and it's because there's two convex surfaces there. So it's inherently unstable, and we can try to treat it without surgery like we do with most MCL injuries. But unfortunately, because the two convex surfaces are unstable, they just don't heal. And we validated this in several animal models, looking at rabbits and goats in a dog model, and found out that they just don't heal because of the bony anatomy. And that was important for us to understand and to validate what we were seeing as as dogma out there in level 5 analysis that you had to treat these, whereas MCLs, you could try to treat them non-operatively. Now, in terms of going in and identifying the anatomy, it's important to, if you're going to see an injury like this, where everything is pretty significantly damaged and the biceps is off and the popliteus is torn and everything else, you want to make sure that you can restore the anatomy and know exactly where things attach. So first off, we looked at the fibular collateral ligament. The fibular collateral ligament at that point in time in Gray's Anatomy was described as attaching on the fibular styloid and coursing up to the lateral epicondyle. And of course, it doesn't do that. On the femur, it attaches a little bit behind the lateral epicondyle and a little saddle. So it's proximal and posterior to the lateral epicondyle. And then its fibular attachment is basically midway along the fibular head. And the biceps bursa, where the anterior arm of the biceps crosses the FCL, is one of our most important surgical landmarks, because if you can enter the biceps bursa, you can identify any remnant of the FCL. And then it makes it a lot easier both to identify where your femoral attachment site is, and also to go down distally on the fibula and make sure you know where those attachment sites. So that's a surgical pearl to think about, is trying to enter that biceps bursa in all cases. And it allows you to make your surgery more efficient, and you don't have to do as much dissection. Now, the Palpatius tendon, and to jump ahead, the tendon functions as a ligament at the knee, so that's important to understand. But it attaches in the anterior fifth of the popliteal sulcus. And this attachment relationship is important to understand for when we're looking at whether we're having one tunnel or two tunnels on the femur, because the average distance that we found between the centers of the attachment site is 18.5 millimeters. And when we first started analyzing this and looking at one tunnel on the femur, which is what most people did, we found out that it just didn't work. And if we look at it now in retrospect and what we're looking at with ACL reconstructions and PCL reconstructions, obviously, if there's that much distance between the structures, it doesn't make a lot of sense as we flex and extend the knee that you can have an anatomic-based reconstruction that's not going to stretch out over time. So once we figured out that distance, when we went back and analyzed having two separate reconstruction grafts in the femur, that made it work a lot better. And that was an important spatial relationship for us to understand that I don't think had been well understood until that point in time. And then the popliteal fibular ligament, which also has been called the arcuate ligament in the past. Arcuate means arched, and some of the landmarks that were described between the 1940s and the 1990s just looked at the back of the knee as a big arch structure, so they called it the arcuate ligament. But the literature before that actually talked about the popliteal fibular ligament. It just got lost in the literature, and it attaches at the musculotendinous junction of the popliteus, and then courses down to the posterior medial aspect of the fibular styloid. And it is an important secondary stabilizer. When it's torn or if it's cut biomechanically, you're not going to see any increase in motion unless something else is injured, either the FCL or your Palpatius tendon. But it does have some importance there, and we'll show you. The specimen that's on the left there is actually a canine knee. And we found out the canine knee is perfect in terms of it matches the human knee exactly for the posterior lateral corner of the knee. So we're able to use that as a good natural history model. We developed some objective tests as we went along. One of them was a heel height test. In my previous practice, where I saw a lot of athletes that were injured immediately off a ski hill, we're finding out that they had an increase in heel height, and a lot of them that had an increase in heel height had an FCL tear. So we went back and looked at it, and if there's more than a 3 centimeter increase in side-to-side differences, we found out it was very consistent with an ACL and FCL tear with MRI and also with stress x-rays. So that's a quick way to help diagnose that clinically. The varus stress test is the main objective test. It's the varus that causes the cruciate ligaments to fail. So you really want to make sure you understand this. And for the listeners who are just beginning out and trying to understand how to treat a knee injury, the varus is key. And you have to check the contralateral knee, because if a patient has any increase in heel height or recurvatum, they will have some physiologic gapping of the lateral compartment. So you have to see about side-to-side differences. The MCL doesn't really have that much difference. It's less than 1 millimeter in people, but the posterior lateral corner can gap quite a bit. So you really want to make sure you check the contralateral side when you're assessing for the gapping, but the varus is the key part here. You also want to have the patients walk and see if there's any problems. So this patient, stress x-rays were 3 millimeters, but you can see because when at foot strike, his lateral compartment is opening, you can see how much this was disabling for him, even with a 3 millimeter difference. So you have to have these patients walk, especially in the chronic situation. This was an acute situation. He was a farmer that was injured when he was farming, and you could see how debilitating this can be. And most of these patients that do have a varus thrust gait or will have some varus alignment. So at foot strike, they're opening up their lateral compartment. And it doesn't have to be a lot of lateral compartment opening. They can just have that gap open and they can develop the thrusting, which sometimes can be difficult to treat when it becomes a chronic problem. Always remember to check for the common peroneal nerve. The common peroneal nerve is completely injured in about 15% of these patients, but also you'll have some neuropraxias and mild functional deficits. And you want to check the dorsal foot sensation, usually the first dorsal web space around the big toe, and check their EHL, ankle dorsiflexion, and foot eversion strength. And probably the most important one to check is the EHL, because you can check it side to side pretty well. And that's the one that is the last one to come back when they do have a foot drop. So it's usually the first one to go also. So if you're looking for subtle differences in some of these patients where they might have a little sensory deficit, you want to check the EHL and see if there's any motor differences there. And then because of the native gapping that's present in the knee, it's very difficult for me or for one of our faculty to be able to say what the difference is in side to side, because sometimes it's hard when they do have some physiologic gapping. And so we developed the varus stress x-rays to look at side to side differences. And a couple other centers have also looked at these and found out that 1.99 millimeters and 2.4 millimeters and 2.2 is important and consistent with a complete tear of the FCL. And you may think that's not a lot, but if you think about ACLs, a KT1000 of 3 millimeters is consistent with a complete ACL tear. So this is in the same ballpark there. And what we found out is that if you have 2.7 millimeters or more of lateral compartment side-to-side gapping, it's consistent with a complete FCL tear. And we did this in a biomechanical study. And then 4 millimeters was a complete posterior lateral corner injury, where we cut the FCL, the Palpatius tendon, and the popliteal fibular ligament. So it's important to know this, because if you're a surgeon, you want to know what you're starting with. And it's also important to know what you end up with, because you want to see if your surgeries are working. And if you're changing your rehabilitation, or if you've done something different and you're doing a new technique, you really want to have objective information to see if it's actually working. And I'd suggest that if you don't do the stress x-rays, please consider doing it, because it'll make you a better surgeon ultimately. MRIs are essential for evaluating these, especially in the acute situations. In the chronic situation, you need them, but it may not tell you all the information, because things can heal, but they'll heal in an elongated position. So the stress x-rays are important. But you can see the cruciate tears, which are almost always associated with posterior lateral quarters. You can look at the Palpatius tendon, other associated injuries such as a root tear that you never want to miss, and other things can go along with these. And then another study that we found out when we looked prospectively at 102 patients was that there's a lot of medial compartment bone bruises. So if you do see these bone bruises that sometimes look like the hyperextension injuries, or posterior medial bone bruises that are under the posterior horn of the medial meniscus, think about a posterior lateral corner injury when you see the MRI. Another thing for some of the young surgeons who may be covering the emergency room is if you see a medial tibial plateau fracture in a young patient, there may be a posterior lateral corner injury with that too, because we were seeing 11% of the time that these patients did have some medial tibial plateau fracture. So just keep that in the back of your mind so you don't miss things, because at the time of injury, some of these patients hurt a lot. It's a little bit difficult to evaluate them. But if you use these secondary signs of injuries, then you won't miss it. And then we went on from these studies to look at an anatomic reconstruction of these structures. So we actually did 9 different pilot studies to get to this point. We looked at one graft, we looked at a graft that was just going from front to back through the fibular head, and then instead of going through the tibia up to the femur, and they just didn't work as well as when we restored everything. So this is actually a picture on the right there as one of our first pilot studies that we did, looking at reconstructing the fibular collateral ligament, then the popliteal fibular ligament and Palpatius tendon. So we're only reconstructing the static function of these structures. Obviously, it's a dynamic structure that we don't quite understand in terms of if that gets restored at all, but it's important to look at where these are, because we try to put them back in the anatomic position, and we're able to biomechanically validate that we can restore stability in these cases. So what it is we have 4 separate tunnels, 2 separate grafts. We're reconstructing 3 ligaments and trying to restore what the native structures were in the first place. And I did this concurrently with the University of Oslo. I think international collaboration is a big part of trying to get to the next level. So if you have a chance to collaborate with international colleagues, it's good, because I could do things in Minnesota that they couldn't do in Oslo, and they had access to a lot of cadavers, so we could go there and practice to see if our surgery techniques were feasible. There were a couple that worked, but they weren't able to be reproduced very well. And this is what we arrived at for having the best way to restore stability to the knee. When we started going out and talking about this internationally, I always get questioned if the PFL graft was truly necessary. So I had a colleague come in from the University of Bologna and spent 3 months with me and did a study where he did the surgeries. I didn't even show up at the surgeries. I had him do them, where we looked at anatomic reconstruction, both with and without the PFL. And we found out that when we did the PFL, the results were significantly better. It wasn't a big difference, obviously, but it did seem to restore the stability better. So the fact that it only adds about an extra 5 to 10 seconds to the surgery to pass both grafts instead of one graft, I'd encourage you to look at reconstructing the PFL also when you're doing this and our anatomic technique, because we did find that it made a difference when we put it in through the tibia. When we looked at our varus translation, if you remember back in 1996, we weren't seeing that we could restore varus. We found out we could restore varus with this reconstruction. And I think the important thing at the time, which gets overlooked now, is that all of the reconstructions at that point in time were over-constraining and external rotation. And some of these patients were having difficulty with normal gait patterns. And we found out that we weren't over-constraining them and basically bringing them back to normal with these 2 grafts that were going through the tibia. So it was, I think I didn't appreciate it as much then as I do now, because I think this part of the surgery almost always works. And even when people get re-injured, it doesn't seem like they have problems with the external rotation. They'll injure the FCL more than they do the Palpatius and PFL. So with our study, we found out that the PFL graft better restored normal motion. There was a little bit more increase in varus and external rotation. And importantly, the PFL graft did not over-constrain the knee. So if we go back and look at all the relevant biomechanics that we found, which built on our new quantitative anatomy study, the FCL is the main varus restraint. So you really can't open up very much at all in varus unless the FCL is injured. The Palpatius and the PFL are the main external rotators. And the posterolateral corner critically interacts with both the ACL and PCL. And we found that also in some of our studies where we looked at the effects of a deficient posterolateral corner with an ACL and a PCL. And basically those grafts are at very high risk of failure if you don't reconstruct the posterolateral corner. And in our animal studies, we found out that the posterolateral corner injuries rarely healed, and that was because of the bony anatomy. We also looked at FCL reconstruction. So I think when I first was out in practice, I was seeing the worst of the worst, or maybe they were seeing me and I wasn't seeing them. But then we started to see more FCL tears with the Palpatius intact. And the FCL wasn't being reconstructed that well at that point in time. One of the ways was to use a patellar tendon graft, but the patellar tendon graft average length is 48 millimeters. and the average FCL length is 71 millimeters, so it's just too short. And there was other types of tenodesis procedures that went from front to back through the fibular head that just biomechanically didn't make sense. So we looked at an anatomic reconstruction, basically taking the FCL portion of our complete reconstruction and testing it. And this restored all the rotatory stability as well as the varus. And I really think this is probably, out of all the surgeries that we work to develop anatomically, this is the one that the patients do the best on in terms of their outcomes. So putting it back in an anatomic location, we use their own hamstring tendons, and it allows them to have good stability with this, and we validated this biomechanically. We also have some of those rare cases where the popliteus can be torn either by itself or with a PCL. And we found out that if we just reconstruct the popliteus tendon, where we reattach it on the anterior fifth of the popliteal sulcus and then bring it back to its attachment point and have basically the same tunnel, but a lot smaller on the tibia, we can restore stability. And most of the athletes that I'd see with this were high-level wrestlers. So intercollegiate wrestlers in the US, where they're brought up in a figure 4 position and their popliteus would be torn. I've also seen it in patients that have a PCL tear with a popliteus. So this doesn't require a complete reconstruction of the posterolateral corner when you have that rotatory instability, and you can just restore the function of the popliteus tendon, and it works quite well. So what about the treatment of these? So we looked at our treatment and basically tried to divide them into acute and chronics. And I'll mainly go through an acute case now. Most of the time when we do see these cases, 72% of the time they're going to be with a cruciate ligament. So that's what we think about when we're treating posterolateral corners, is think about what else is going on. So this is an example here of an athlete. I can hear the groan from the people watching it. And he came down and had a pretty significant injury. So preoperative planning wise, when I'm thinking about seeing somebody like this, I need to combine my exam and the MRI. I want to make sure that I get the proper stress x-rays so I know what I started with. And it's an appropriate question to say, well, can they put full stress on their knee and are we getting good in numbers? They probably can't, but I still want to get the stress x-rays so I know what we start with. Because if the PCL measures 12 and maybe it's 20, and I can get them down to 2, at least I know that we made them a lot better that way. And if there's any doubt, we'll get stress x-rays in surgery. I had 2 cases yesterday where I got stress x-rays in surgery. So I don't hesitate to do that. We bring in the fluoroscopy and it's pretty quick. Also, when I see them acutely, I want to try to operate within the first 2 to 3 weeks. It's important to get in before everything turns to scar. And the common peroneal nerve is difficult to identify. It looks like scar after a couple of weeks. So you're not sure if you're operating on scar or if you're operating on the nerve. So we'll try to get in within the first 2 to 3 weeks if possible. We want to identify the peroneal nerve injury ahead of time. It's not uncommon for my fellows to go examine a patient and then there was a partial foot drop and they didn't even check the nerve. So remember to always check the common peroneal nerve function in these patients because you can miss it. And then we try to address all the torn structures in these acute cases. You can identify all the torn structures, reconstruct the important ones, and then you can repair the lateral capsule, iliotibial band, biceps avulsions, and all those other injuries at the same point in time. So the surgical steps are basically the same every single time. And we can do these cases in about 15 minutes because we've done a lot of them. And my scrub tech can hand the instrument to me before I ask for it. So we just follow the same steps. All my team knows what the steps are going to be. And if you know the anatomy, you can do it. It doesn't have to be 15 minutes. If it takes you 45 minutes, that's fine. But you just want to make sure you know the anatomy and you're quick and efficient. And that way the patients recover better and have less stiffness. So we'll develop the posteriorly based skin flap. I make that same incision. I don't believe in making small incisions for these type of cases because if you do, you may miss something and it's a lot harder to see your structures. And the patients want a surgery that works. They're not too worried about the scars when the surgery works. So you want to make sure the surgery works. Next step is we always do the peroneal nerve neurolysis next. I want to make sure I identify the nerve, get it out of the way. I don't like to put a Penrose drain or anything around it. We used to. If you look at some of my old presentations from 15 or 20 years ago, we put a Penrose drain. But I was finding out that sometimes your assistant didn't put traction on the nerve, so I don't do that. Then we'll prepare the tunnels. So I start off by drilling the fibular head tunnel first, always. If we need a Palpatius reconstruction, we'll drill the tibial tunnel next, and then we'll identify both tunnels on the femur, measure between them, and then ream them. Then we'll go in and address the intra-articular pathology. Usually I'd say cruciate or two and meniscus or two to address. Meanwhile, my surgical team will prepare the grafts. Then when everything's all set, we'll pass and fix all the grafts. And we try to get full motion started on postoperative day 1. You don't need to use a tourniquet if you think your operative time is going to be long. We're usually doing our multi-ligament surgeries in about 90 minutes because the team is quick and efficient with me. So I use a tourniquet because I feel I can go a little faster and get the patients off the table, and it's less chance of having infection, arthrofibrosis, and blood clots if you can do that. So the first thing is to do the exam under anesthesia, making sure you can see what's going on. So you can see in this case that the PCL is obviously torn. His 12 millimeter stress x-rays probably underestimated things. See the difference? And you always want to check to the contralateral side. So do a thorough exam under anesthesia. Even if you're a high level faculty or you're a junior assistant who's normally covering the emergency room, try to get in and do these EUAs, because one, at the time of surgery, you know exactly where to go. And number two, when you see somebody in clinic, the more that you do in surgery, the better chance that you'll be able to understand what their pathology is when you can correlate what their clinical exam was and their exam under anesthesia. So the posterior lateral corner approach, this is the patient that you saw that fell down. We're making a lateral hockey stick incision. You can see the significant trauma that developed here because there's a pretty significant injury. And then we're trying to go down and identify the nerve. So in his case, he had a complete biceps avulsion. When you see a biceps avulsion, you have to be a lot slower in making sure that you identify where your pathology is, because the nerve can actually go up and over the fibular head. So you have to slow down your surgical approach whenever you see any biceps avulsion on your MRI scan. The next thing is to do the common peroneal nerve neurolysis. So you can see I'm putting a Penrose drain around it, but I don't do that anymore. We make sure we go along the posterior border of the long head of the biceps. And if it's a really bad injury, sometimes you have to start more proximal, or sometimes you just find the fibula and dissect down 2 centimeters below the fibular head to try to find some of the fibers, because if it's completely caught up in scar, especially if it's 3 to 6 weeks after injury, it's really hard to identify it. So try to think about other ways based on anatomy. And you have to do a neurolysis to be able to get to the back of the knee and drill a fibular head tunnel and drill a tibial tunnel. When you do see the biceps avulsions, you can see my hemostat is showing where the nerve is. In this case, the nerve was actually up and over the fibular head. And if I had gone down too quick on this, I could have damaged the common peroneal nerve. This patient actually did not have a foot drop, even though the nerve was quite stretched and malpositioned, their function was still there. So use that also in the back of your head as part of your evaluation, is if the biceps is avulsed, do you think maybe the nerve is malpositioned, so you have to go a lot slower in your surgical approach. The next thing is to identify where the FCL attaches. So we'll make an incision in that biceps bursa, and then I can dissect down and find out where the FCL is attached. The FCL is a lot like the PCL in that it stretches out, but it doesn't tear in two. Most of the time when we look at an ACL tear, you can tell pretty well on the MRI that it's just blown apart with spaghetti ends, whereas the FCL just tends to stretch out. And that's why in chronic cases, the stress x-rays are essential, because we found out that only 70% of the time a high-level musculoskeletal radiologist was able to call an FCL tear in a chronic case. So the stress x-rays are definitely what you have to use. And sometimes even the acute cases, because you don't see the FCL as well. But find that bursa, because when you find the bursa, it's a lot easier to identify where it attaches in the fibular head. And then you can drill your tunnel. We like to do an anatomic reconstruction. So we'll go on the lateral aspect, drill a guide pin, make sure I palpate and see exactly where it is. And for our complete reconstruction, we use a 7mm reamer. For just the FCL itself, we'll use a 6mm reamer. And obviously, if you have smaller patients, you'll want to downsize it. And if you're using hamstring grafts instead of the allografts like we use, you can use even smaller, possibly a 5 or 6mm reamer. That doesn't really matter. It's just a matter of making sure that the grafts pass easily so they don't get bunched up and have a problem with them. And then making sure that your interference screws match the size of the tunnels. The tibial tunnel, I have this picture here. This is one from Norway. That's why the instruments look pretty archaic here. But you can see where I'm having this retractor in the tunnel on the tibia comes in just below where Gerdy's tubercle is. So there's a flat spot there that you can feel on your own knee. And it's just a little bit distal and medial to Gerdy's tubercle. And it's a great position to drill your tunnel, because if you drift a little bit lateral from there, you can enter where that muscles are, so the anterior compartment, and that guide pin can actually slide down and enter the proximal tib-fib joint. I've had that happen in some very obese patients where it was hard to see their landmarks. So you want to find out that flat spot that is anteriorly located distal and medial to Gerdy's tubercle. And then posteriorly, it exits at the musculotendinous junction of the popliteus. And the landmarks that you'd want to palpate for when your guide pin is in first is that if you stick a blunt obturator, or in this case, I have a pickups through the fibular head tunnel, the tibial tunnel should be 1 centimeter medial and 1 centimeter proximal to that. So that's your landmarks, because it's not a straight across horizontal graft. It should be up a little bit. And you can just palpate back there and make sure it's in the correct anatomic position. So we'll enter at that flat spot, just distal and medial to Gerdy's tubercle anteriorly, and exit at the popliteus musculotendinous junction. For our reconstruction, we use a 9mm reamer. Our Norwegian colleagues use a 10. For the popliteus reconstruction, we use a 6 or a 7. So you can use whatever size is necessary here based on your graft. But we use allografts for the majority of these, so we're using a 9mm tunnel to make sure that we can pass our grafts from posterior to anterior in this situation. Then the iliotibial band split is next. So obviously this picture is pretty dramatic because it's a pretty bad injury here. But what I want to do is to try to make sure I'm a little bit proximal to the attachment site, because if you're a little bit distal, it's hard for your assistant to actually retract up and show things. And if you make your incision just a little bit above your popliteus and FCL attachment sites, it's a lot easier to be able to identify them. And then so we'll go down and try to find one or the other, and then measure and find the other one with an average 18.5. So if you have patients that are smaller, remember, this is an average 18.5 in Norwegian knees. So it's possible that it's going to be 16mm. The important thing is just find your anatomic landmarks so you can put them in the correct position. So you can see I'll split my iliotibial band here and dissect down. And then find out where the popliteus and the FCL attachment sites are. And it's important to dissect down. You can even see in these really bad injuries that we can still find good tissue planes and be able to restore the anatomy. I think one of the surgical pearls here is to make sure you put both of the guide pins in, and then measure between them, and then ream the tunnels. Because if you put one guide pin in and then you ream the tunnel, if that guide pin's not quite in the right spot, then your second tunnel may not be in the right spot. So put both pins in first, measure between them, make sure that that's where you truly want to be, and then ream the tunnels. And then it doesn't waste any time to do that. And then you have a better chance of making sure it's a truly anatomic reconstruction. So we'll ream 9mm tunnels to a depth of about 20mm. If you're doing a concurrent ACL reconstruction, you have to aim more anteromedial, because if you go straight across, the FCL tunnel is going to merge with your ACL tunnel. And that's probably the only time we have to worry about convergence. Our biomechanical studies show that the popliteus doesn't converge, at least if you're doing an anatomic ACL reconstruction. So the FCL is the one you have to make sure that you aim it appropriately so you don't have it converge. Graft preparation, Lars and I have always done a split Achilles tendon. I've done some studies with some colleagues in Brazil and also in Argentina, in Chile, where we can use hamstring grafts, and their clinical studies show that those work well also. So you can use those. We've always done the Achilles because we have so many studies and we don't want to change it. So you can have a bone plug of 9 by 20 millimeters, and you can tubularize the remaining tendon. Remember, the average length of the FCL is 70 millimeters, and the Palpatius tendon is 60 millimeters. So if you do use an allograft, you can leave the graft a little bit bigger along that length. That way you have a little bit more tissue to work with. Then the fibular tunnel. So this is obviously looking a little bit strange because the biceps was torn off the fibular head. But you can see in this case that we have that I've identified where it attaches, I drilled the tunnel, and then I placed a passing stitch. So we do that right away in surgery. So we get this done before there's fluid extravasation in the knee arthroscopy. Then the tibial tunnel. So once again, I'm at the edge of the patellar tendon by Gertie's tubercle. Posteriorly, I'm making sure that I go back to the musculotendinous junction, and then we'll place a passing stitch here too. And then the final one is to split the iliotibial band, dissect down so you can see that I've identified the Palpatius, and I'm measuring to make sure that I know exactly where the tunnel should be, and then placing in the 2 guide pins, and then finally over-reaming them to make sure I'm in an anatomic position. And I always like to place these passing stitches because later in the case, if you have to put a bead pin through and pass a graft later, it's a little bit harder. So we have passing stitches all over the place, obviously, if you have a foreligament reconstruction. And you just make sure that you have hemostats on the end of those, and then it's easier to pass the grafts at the end of the case when you start getting more fatigued. So this is showing that this is a case with a PCL here, where I'm using a smoother in the back of the knee, then putting my grafts in. So there's one of the bundles already in place for a double bundle PCL, and I'd put in the second one with the bone plug for the anterior lateral bundle of the PCL. And I put the sutures in the end of the smoother so you can see both grafts there, and then it's easy just to pull it down the tibia. So double bundle PCLs work very well with these reconstructions also. Then we'll fix them separately on the tibia. And for the fixation of the FCL and Palpatius, they're pretty easy. You just pass the grafts in, fix them. If they're soft tissue grafts, you can use biabsorber or PEEK screws. If you're using a bone plug, I like to use metal screws just so I can see the x-rays. And then passing the FCL graft under the iliotibial band, and then through the fibular head tunnel. Even with the biceps avulsed off, you can still put things back in anatomic position. And then fixing them, it's important that you fix the FCL at about 30 degrees knee flexion. So here's the Palpatius and PFL being passed from anterior to posterior. You can see it's not that hard to do that. And then we fix them at 60 degrees knee flexion and neutral. You don't have to over-constrain the knee and turn the foot in internal rotation, because those patients don't do well. If you look back to our biomechanical studies, these they don't need to be over-constrained. So you can just put them in neutral rotation, and these patients will get normal motion back. Rehabilitation, we're being more aggressive than what I was taught. When I was first taught, we used to cast these. And now we're doing some protocols with level 1 studies looking at early weight bearing. But we start range of motion. If there's a PCL, we start prone knee flexion at 0 to 90 on day 1. So we don't keep them in extension at all. The systematic reviews show that early motion helps a lot with these cases, and they get back to activities sooner. And then at 6 weeks, where weight bearing is tolerated, and then if there is a PCL, you want to use some type of dynamic PCL brace. So here's this patient post-operatively. You can see his varus stress x-rays show that he's healed his complete posterior lateral corner. The PCL stress x-rays, he's within 2 millimeters of side-to-side difference. So I was pretty happy because he could get back to function. So there he was at 1 year post-op. And I don't think when I started out, there was any way that any of us could have got an athlete back to that level of activity. And now it's routine, as you'll see from some of our clinical outcomes, that we can get these patients back to high levels of activity with anatomic reconstructions and marrying that with a good rehabilitation program. So first off, when we look at some of the things that ESCA has done, they looked at both what people use and what experts recommend. And if you look at the expert groups, basically they're saying the same things that I just went through. Obtain an MRI, obtain varus stress x-rays, try to operate within the first 2 to 3 weeks, and anatomic reconstructions instead of repairs. And people can argue about what's an anatomic reconstruction, but I think the lesson to learn is that repairs don't work as well. The systematic reviews show that they stretch out. So you should do a reconstruction of the Fcl, Palpatius Tendon, and PFL when they're torn, because repairs don't work as well. But what are people actually doing? Well, when they looked at a large number of people across the world, what they found out is that 53% of surgeons were doing repairs. They're generally low treatment numbers, so they're doing 1 or 2 a year, which obviously it's hard to follow your outcomes if you're only doing a couple. And then there was multiple reconstruction techniques that were done. Still some of the biceps tendon, which was quite antiquated from 2 decades ago, but there's some that look at 1 femoral tunnel and 2 femoral tunnels and fibular. But I'd encourage you to look at the literature and decide what you're going to do based on your own certain situation. But we've been able to validate what we do, and we're really, really happy with it. And that's what most of the experts follow. So when we looked at our outcomes of our acute posterior laterals, this was published in JBJS. We looked at our patients, and so we had the preoperative varus stress x-rays and compared them to follow-up. And remember, these were pretty aggressive in terms of what the literature was at the time, where most of my colleagues were treating these in extension for 2 to 3 weeks and afraid to move them. We were starting them moving on day 1. And one of the concerns I was getting from the podium is that multiple people would criticize us and say that these were going to stretch out, they're not going to do well. And we validated that they actually didn't stretch out at all, with 0.1 millimeter gapping over time. And their Cincinnati scores were pretty significantly improved for a multiple ligament reconstruction, as well as their IKDC scores. So we're making some good steps with this, and they weren't stretching out. For our anatomic Fcl reconstructions, our outcomes were also showing similar amounts, where these patients were not stretching out and having improved Leishman scores. And I actually think they were some of our most successful surgeries. So we're able to restore these patients to high levels. So we validated our anatomic and biomechanical studies clinically. For the Palpatius tendon, we showed that we also had significantly improved Leishman and Tegner scores, and when they were done with the PCLs were working well. So we validated the Palpatius were working. For our chronic posterior laterals, so this was a professional athlete here, and recognize this was surgeries that were done 20 years ago. We're improving their Cincinnati scores, but not the same as the acutes. And the varus, we weren't getting stress x-rays back then when we started in 2000, but you can see the varus was not clinically different. And that's why you should use stress x-rays, so you can have more objective information. Then we more recently published our outcomes on 194 patients that had multi-ligament reconstructions, and with a relatively aggressive rehabilitation program, so early range of motion, and seeing how they did. And we found out that there wasn't any difference in these patients with ACLs or PCLs or combined. And our outcomes were significantly better with the Leishman scores and IKDC scores of 90. So they're almost equivalent to what ACLs were. So you can treat these patients and get them back to high levels of activity, even with these severe injuries with anatomic-based reconstructions. And you can see that our stress x-rays were showing they were not stretching out, and our outcome scores were significantly improved. So I think we made a lot of improvement over the last 20 to 25 years based on a lot of science to help us get to a higher level of treating these patients. So in summary, I know this is a basic course, but this is a complex topic. I think probably the most important thing first off is to understand the anatomy. If you understand your anatomy, you can be a better surgeon. you can be more efficient in surgery. And I think that when you're more efficient in surgery, your patients have less complications and less chance of being stiff. Look at doing hybrid repairs in the acute situation, as well as the complete reconstruction. So you can repair your lateral capsule, you can repair your iliotibial band, you can repair your biceps, in addition to reconstructing the Fcl, Palpatius tendon, and PFL. I'd ask you to consider an anatomic posterolateral reconstruction. We've now been able to have multiple papers that have shown that these do well over time in JBJS and AJSM. So take a look at it and see if that's different than what you do, and if it compares to your outcomes, or maybe it's a little better than your outcomes, and you should take a look at it. And try to operate early when possible. These patients' outcome scores are significantly better when you can operate on them within the first 2 to 3 weeks. Our stress x-rays, if you notice, that they are not different at all. So we can actually restore stability pretty good in these chronics with a proper workup, but the patients just do better. And I think it's because all the other structures that are injured heal in a stretched out condition. And if you operate on them sooner, you can restore stability better, and they do better overall. Thank you very much.
Thank you very much, Dr. Rob. It was a wonderful information-loaded program. Thank you for sharing your experience so far. Without much ado, I kindly request Dr. Sundararajan and Dr. Bobby to take over the program and share your experiences and questions.
Firstly, sorry for I was running a little bit late, and in fact, I was in clinic and I had a PCL and posterolateral corner. That was my last patient today. So it was really wonderful to listen to the talk from Professor LaPrade. It was really some brilliant tips and wisdom, you know, from the posterolateral corner surgeon, really. So firstly, thank you. Secondly, I think it was convincing enough for me to, you know, my next case, I'm definitely going to try your technique. I did try it about 6-7 years ago, and I struggled with it when I was starting out. But I think I'm slightly better now, so we'll definitely give it a go. I've got quite a few questions, but I'll start off with one or two, if I may. I often, and I don't know if it's the same for the other guys on the panel, I often inherit cases that are chronic. I don't do acute trauma, so I often, the patients get referred across, like the patient I've just inherited, who's a fighter, a MMA fighter. By the time they get to me, they're already about 6 months old. And so is your management different in that situation, or do you do the same? So that, I suppose that's the first question. And tagged on to that is, the last few years, I've started using a lot of synthetics for the posterolateral corner, and I use it for the PCL. And, so far I've been pretty happy with it. And allograft in the UK is very expensive, and it poses other challenges for us. So what's your view on that? Is that an accept, how would you view that, Professor?
So first off, to talk about the chronics, you have to look at them a little differently, because if they're in varus alignment, there's a high risk that they'll stretch out if you don't do a first stage osteotomy. So you have to look at that. And also for PCLs, you want to get a full length tibia x-ray and check their slope, because if they're a flatter slope and you do a single bundle PCL, the literature suggests that they're going to stretch out. So that's more of a definitive time that you have to look at a double bundle PCL reconstruction. And if they're in varus alignment, then you just have to do the osteotomy first. And it's really hard to do these type of reconstructions concurrent with an osteotomy. So I'll do the osteotomy first, let them heal, let them rehab. And then most of the time, unless it's a really low velocity isolated injury, they'll want to have the second stage reconstruction after they've healed the osteotomy. And that's usually about 6 months. So I look at coronal plane alignment, I look at sagittal plane alignment, and it's important to put all that together. And it's the same thing with a ACL and a posterolateral corner. If you're in varus alignment, you have to make sure the slope isn't too much posteriorly, because if it's 12 degrees or more, then there's a much higher risk that your ACL graft will stretch out. So you want to try to decrease the slope. So looking at both planes is important with these chronics, and you don't necessarily have to look at it, except in very rare cases for the acutes that maybe had some type of growth arrest that I see. But hopefully you haven't seen it that much. In terms of synthetics, I have concerns about it because there multiple times in the past synthetics have been used. My colleague in Norway is very adamant about not using synthetics. I think if you're going to do them, you should get the pre-op and post-operative stress x-rays to make sure that you have some objective information, because all of us, when we do surgery, we want to think our cases are doing fantastic, but the stress x-rays are going to tell us if we're actually doing well or not, especially for PCL. So I'd encourage you to look at stress x-rays. I've reviewed several papers on acute use of synthetics for PCLs, ACLs, posterior lateral corners, and they did stress x-rays, and the PCLs were averaging 8 millimeters at 2 years, and the posterior lateral corner was 2 or 3 millimeters, and they're saying they're doing fantastic. Well, in our data, that shows that it completely failed. And maybe they're doing okay, but you know, some PCLs do okay for a while that are moderately stretched out until they start developing arthritis. So just be careful and analyze your data if you're going to do that, because you're right, not everybody has access to allografts, and you may have to do that. But there's also the possibility, I know with some places, including Norway, occasionally they'll go to the contralateral knee to get grafts if they need to, because you can use a quad tendon, you can get a BTB, you can get a hamstring graft or two from a contralateral knee also if necessary. And I've done that in some of my situations with revision cases, because in revisions, I'm trying not to use allografts as much as I can. I want to try to use autografts to make sure I have the best chance of healing.
Yeah, thank you. That was really helpful. The only other bit I was going to add on to your comment is when you're adding that osteotomy in, I think that's fine for you know, a fair chunk of my patients. But when you've got the, you know, an athlete who was a serious athlete, once you add the osteotomy, what's your experience of them getting back to you know, usually it's fighters for me, MMA fighters. I'd be very nervous about adding that component.
Yeah, I think that's a good comment. I think in my practice, where I see a lot of professional athletes that have failed surgeries, I think it's important to recognize that you have to treat everybody the same. You have to be careful about cutting corners in professional athletes, because those are the ones that I see that have failed, and they're no longer professional athletes, and they'll go around and try to figure out what's going on. So when I've done osteotomies in the appropriate cases, I've gotten athletes back. They're not at the same level, of course, because they have so much extra surgery, but at the same point in time, if you skip the step for a particular portion and the literature tells you that things aren't going to work, well, it's probably not going to work, because these athletes are big. They have a high moment arm that they're going to put across their grafts, and they're not doing low functional activities where they're not going to stretch their grafts out. So I'd be careful for anybody that's listening to treat their high-level athletes any different than they treat what has been shown with evidence-based medicine to be the best way to treat them, because I think you'll end up hitting a home run and doing better in the long term with these guys if you treat them on what the gold standard is, rather than trying to cut corners because they're a high-level athlete.
Thank you.
Okay. Thank you, Dr. LaPrade. I think it was a wonderful comprehensive talk where you had put all your work and showed us within 40 minutes. That was wonderful. And also, I'm happy to share that we run live surgical courses in our institute, which is attended by 500 to 600 delegates. And last year, I did your technique on one of the patient on PCL with PLC. And coming back to the questions, because most of the patients which we treat, especially in the multi-ligament injuries, are not professional athletes. Mostly what we have are road traffic accident patients. So I would ask some few basic questions, like when you decide about surgery on the PLC injuries, do you rely on only about your radiological side to side difference with the 2.7 and 4 mm, or do you correlate with the clinical finding, whether the patient has got only lateral opening and external rotation?
Yeah, that's a good question. My clinical exam and my exam under anesthesia, I consider the gold standard. And if the stress x-rays are 4 millimeters and I'm worried about it only being an FCL tear, I have that in the back of my mind that maybe I have to look for the Palpatius. So when we do our surgical approach, I'll drill for the FCL, but I'll also make a small incision in the lateral capsule to check the Palpatius function and see if it's loose or if it's torn off at that location. So it's a good question. I actually had one yesterday that I did that because the MRI looked bad, but clinically the dial test and posterior lateral drawer tests were intact. And then at the time of surgery, the patient just had some intersubstance changes that made the MRI look like it was torn off, but it wasn't. So you don't want to go specifically on one particular piece of information. And for those of you that are just starting out and evaluating these, sometimes you have to put everything together to be able to make the right decision. You can use your clinical exam, the stress, but sometimes you just have to use your own vision and just make a little bit more of an incision and dissect down and validate it. So you don't want to be the guy that you don't go and investigate it further and miss one of those things. You want to make sure that you treat the whole injury pattern so you have the best outcomes. But that's a good question.
In the same vein, sometimes when you decide to do PCL reconstruction with the PLC by your technique, LaPrade technique, by clinical and radiological correlation, sometimes after PCL reconstruction, we find sometimes that axial rotation is significantly reduced. And so in that situation, still you go ahead you advise to do a Palpatius reconstruction or just FCL reconstruction is enough?
If the structure is still intact, you don't need to reconstruct it. And that's a good question because that was one of the questions for the expert consensus, where the international group that they asked that didn't do a lot of these surgeries, a lot of people were doing a complete reconstruction, even if the Palpatius wasn't injured. And you just have to do the FCL, and that's obviously a lot less surgery. And the FCL, if you look at our stress x-ray results, those very rarely stretch out and have problems. So you can use an autograft hamstring and have that work, and you don't have to do the bigger surgery as if they don't rotate. If the Palpatius is intact, you don't need to reconstruct it. Just do the part that's torn. And likewise, if they don't gap and varus, but they're rotating and they have a significant increase in posterior tibial translation, then you want to do your PCL reconstruction with a Palpatius reconstruction at the same time.
And another question is, we tend to find sometimes very small knees, especially in the females. We do have a lot of road traffic accident patients with multi-ligament injuries. We do have a small femur. So at the time, it's very difficult for us to make 6 mm or 7 mm tunnels, 2 tunnels, independent tunnels for the both Palpatius and for the FCL. So if you can make in one channel, I mean, if you have any experience on that, or where do you suggest to put us one tunnel, single tunnel for both tendons?
So I would suggest downsizing the size of the tunnels rather than trying to put in one tunnel, because when I do these in younger patients, so in 10 or 11-year-olds that obviously are pretty short, for us, we measure in height. So we're looking at athletes that are less than 5 feet in height. So it's probably similar to what you're talking about. We have to do them under fluoroscopy. We can still drill 5 and 6 millimeter tunnels without having them converge. So I'd encourage you to look at that as an option, because people have done one tunnel in the past and got them to work okay. But when we looked at our studies overall, patients do better if you have 2 separate tunnels, because you can start early motion. There's less chance it'll stretch out. And I think if you don't have the grafts and you're going to do one tunnel, then I'd be careful about moving them too soon, because of where the cam is in terms of where things move, there's a higher likelihood that they could stretch out over time. So you want to cut back in your motion and let them scar in a little bit more and heal before you get aggressive with the range of motion.
Thank you. Sasi?
Dr. Srinivas, do you have any questions?
May I ask a couple of questions, Dr. LaPrade? Thank you very much for your excellent talk. My questions are basically related to fixing the fibula to the proximal fibula to the tibia, given that most of the structures are, the posterolateral corner structures are attached to the tibia, how common is the injury to the proximal tibiofibular joint? And do you think there's a component of injury to the joint along with injury of PLC? And also, you have alluded to this point during your talk, replacing a dynamic structure like the Palpatius tendon with a static structure using the tendon during reconstruction. So what effects do you think this causes in terms of function of the knee? We are replacing a muscular tissue with a static tendinous tissue while fixing the proximal tibiofibular joint.
Okay, those are good questions. In terms of the proximal tibiofibular joint, I think there's a lot of times that there is some instability there. And I see a lot of those patients in referral. I've had a large series that we've just published on them. And it's important to recognize that the anterior ligaments in the proximal tib-fib joint are very strong. They're about 600 newtons, whereas the posterior ligaments are only 200 newtons. So there's a much higher risk that they'll tear. And when you're drilling your tunnel and putting your fingers around the fibular head, you can kind of move the tibia back and forth or the fibula back and forth to see if there's any instability there. And that'll help you to understand if there's instability. The reconstruction that we do obviously is going to address that very well, but it's probably good to document if they do have some instability, especially if you're doing research and you want to move forward and have some documented instability. In terms of the other question, that was very similar to what we talked about, is that, I mean, that's a question I get asked all the time from the podium, and we don't know what the difference is in terms of what's going on with the function of the muscle. We do know that when we cut the Palpatius tendon, that when the knee is flexed to 90 degrees, there'll be 15 degrees of external rotation. So it does have a function as a ligament in the knee, because when you cut it, it causes significant increases in rotation. It's actually the most rotation of any structure that you can cut in the knee. So it's important there. So we're restoring static stability. In terms of dynamic function, I think it's, if anybody's out there and can think of a way to restore the muscle to the graft, I think that would be a good study to look at. We're not seeing any problem with our high-level athletes, and I'm starting to see some of my posterior lateral corners back that are 20 years post-op, and they're not having functional deficits on that side of the knee. But of course, you know, only time will tell if that's an issue. But most of the time when you do tear your Palpatius tendon, of course, the muscle isn't going to work anyway. So I don't have a good answer for that, but we're able to go to the lab and validate that we have to add that Palpatius portion of it to get the best outcome and restore stability the best.
Thank you.
Thank you, Dr. LaPrade. I have very simple questions. As a continuation of the question by Dr. Bobby, do you have a cutoff point with respect to the varus deformity or the flatness of the slope of the tibia beyond which you want to proceed with an osteotomy?
So that is a good question. My cutoff point is if anything is medial to the apex of the medial tibial eminence, that I'll do a proximal tibial osteotomy. And the reason I say that is because I had one patient that was just in a little bit of varus, and I decided to do the reconstruction and not do the osteotomy in a chronic case, and it stretched out. So Frank Noyes has published in a lot of this, as well as Rolly Jakob and some others in Europe, and Werner Mueller, that if they are in varus, there's a high risk they'll stretch out. And maybe with our anatomic reconstructions, it's not as much of an issue, but I saw one early on. So I used the apex of the medial tibial eminence. Remember, that's 43% of the way over. So if you're just a little bit more into the medial aspect of the joint, you're going to be in the 30th percentile of some sort. So it does have the chance to have that increased adductor moment, which can cause your graft to stretch out. In terms of the slope, the normal tibial slope is between 7 and 9 degrees. And we know that for PCLs, if it's 6 degrees or less, that there's a higher risk that your PCL reconstructions will stretch out. And we know for ACLs, if it's 12 degrees or more, our colleagues at Paczynski's group and Lucy Salmon have published that their failure rate for hamstring ACLs in adolescents that have 12 degrees or more is 78% at 20 years. So 12 degrees is a definite cutoff. And our biomechanical studies validated that. We started seeing the significant increase in force on an ACL graft once the slope was 12 degrees or more. It went up all the way, but at 12 degrees, it became higher. So if it's more than 12 degrees with an ACL, we'll want to decrease the slope. If it's 6 degrees or less with a PCL, we have to be concerned about increasing the slope to make sure that the cruciates ultimately don't stretch out. So that was a good question.
Okay, thank you very much. And just one more question. And if you decide to do an osteotomy, there are tip you would like to say with respect to placing the plate, because you possibly want to do a reconstruction later. So where would you like to put the plate?
So you want to position your plate so that you can change the slope. And I take my plates out when I'm doing the surgery because I don't have a ream that's strong enough to ream through any of the structures that I use for my screws and plates. So I take the plate out, but I want to make sure with an ACL that I'm putting the plate as far posterior as possible. That way I can decrease the slope in the front and hold it down with a staple or something like that. And for a PCL, I'm going to put the plate as far in the front as I can to be able to increase the slope. And then if it's just pure coronal plane changes, you have to decide if you have an ACL or a PCL with it to decide where you want to put your plate. I use a slope plate. I use an old-fashioned slope plate, which is good for my practice because most of my ligaments that are chronic require some type of osteotomy. So we're doing a lot of osteotomies to address the ligament pathology.
I have a couple of questions from audience actually. There's one from Dr. Chaudhry Mohammed. He's asking, what is your opinion regarding peroneus longus tendon for reconstructing multiple ligaments? And there's one more question after this.
So that's a good question. I have no experience with it. I've seen some patients that have come in from Russia and Eastern European countries that have had the peroneus longus. The reason they came to see me is because their ankle function was significantly diminished after they had that graft. So it's not a graft that we use as far as I know in the US, and I don't have any experience with it, but I've seen that there are some complications with robbing Peter to pay Paul in terms of having some decreased ankle function. So I'd encourage you, if you use that graft, to make sure that you know what the effects can be in the ankle and taking some care ahead of time to make sure that doesn't happen in your patient.
There's one question from Dr. Bhaskaran Kumarasamy. He asks, what is the minimum thickness of graft you would advise for FCL and Palpatius reconstruction?
So that's a good question. The FCL strength is 300 newtons. The Palpatius tendon strength is about 700 newtons. And a gracilis tendon strength is about 900 newtons. So a gracilis in general, on average, should be strong enough to reconstruct both or one of those. And the semitendinosus being 1200 newtons on average is more than strong enough, even when you take into account that the grafts will become weaker over time. So I think as long as you have the ability to have good solid fixation in the tunnels and not have your interference screws cut your grafts, that most grafts will be acceptable when you use a tendon graft for either the FCL or Palpatius tendon. So that's a good question.
And when you do an osteotomy with the ligament reconstructions, do you do it in a single stage or you do in 2 stages?
So when we're doing the osteotomy, most of the time we're doing it because they have other ligaments involved. So I'll do it as a 2-stage surgery. The only time I'll do it as 1 stage, like I had one this week, is if they have an FCL that needs to be addressed and they're in varus alignment, I'll do the FCL concurrent with the osteotomy because the tunnels aren't going to converge and the FCL is not going to interfere with your osteotomy, plate fixation, or screw fixation. But I think it's very difficult to work around it and try to get the best chance of having optimal graft position and fixation if you're trying to do it in one stage. That's just in my hands anyways.
Just one more, Dr. LaPrade. Do you tailor your reconstruction in patients depending on the amount of reconstruction or rotational instability associated with PLC injuries?
So what we do is we reconstruct them if they're torn and they either have a significant amount of gapping clinically and or on x-rays, and then tailor that to the exam that you get when they're asleep. So if there's a concern about, is it a grade 2 or a grade 3? I think that's what the question is talking about. I think you have to look at clinically how much rotation is present and what you may be reconstructing. If you're doing an ACL and posterolateral and maybe the Palpatius is just injured a little bit, whatever that is, maybe their dial test is only 5 degrees instead of 15 degrees, and you think there's a chance to heal, well, then maybe that would be a time to look at just doing your Fcl reconstruction, because with an ACL, the Palpatius causes external rotation, ACL becomes unloaded. So your ACL isn't going to be hurt if your Palpatius is a little bit loose ultimately. Whereas with a PCL, that external rotation causes a PCL to fail. So you probably need to reconstruct the whole thing. So I think you have to tailor it based on the injury pattern you have and the amount of instability that you have to decide when you have a partial injury, if it's something that should be reconstructed, or possibly if you can try treating it non-operatively with the rest of the reconstruction.
Okay. Do we have any more questions, Dr. Sundar and Dr. Bobby?
No, I think Shri touched upon that question I was going to ask was, and Professor LaPrade touched on it on his talk as well, in terms of the healing potential of the posterolateral corner. And as you was, I've certainly had cases where you look at the scan and it just looks like there's been a big explosion in the posterolateral corner, and a lot of them clinically have healed up and are pretty stable. And and then you have other cases where you can see the injury and there's less trauma, but they're highly unstable. And so I always base my posterolateral corner decision on the clinical examination, which is usually in clinic, which is, I appreciate that that's not ideal, and ideally you'd like to do an EUA in theatre. But there's definitely a group I find that get away without an intervention. But I wonder if there's any tips you can give us on imaging and signs that we should look out for, where we should get on and intervene, and others where we can wait.
So that's a good question, and I don't think anybody has a good answer to that. If you look at the literature, the success rate at treating posterolateral corner injuries non-operatively is 12 to 15% in the published studies. So, and that's not assessing stress x-rays after they've healed. So we don't know if they've truly healed enough to be able to say that they've healed sufficiently to restore total function. So I think it just depends upon when you see the patient and have the injury pattern in terms of how unstable they are, because some maybe you think it's maybe a high grade 2, and you want to follow them along. Their alignment is okay, so you don't have to worry about an osteotomy, and that's entirely appropriate to do that. But if they're in varus alignment and they have a posterolateral corner, you just know that the results of repairs aren't good. If you wait and they're unstable and they need an osteotomy, they're not going to do as well. So those cases, you want to bring the surgery in that 2 to 3 week time frame and give them the best chance of having a good outcome. So I think it's just like a general surgeon deciding when to do an appendectomy. You want to make the best decision for the patients, and maybe you overtreat a couple and have them have surgery that maybe they would have done okay without having surgery, but it's better than having the patients that don't do okay and their function isn't as good and need an osteotomy down the line.
Okay. Okay, thank you very much, Dr. Rao. I think it was a wonderful program. We have touched upon most of the basics, evolution, and also the outcomes of management, especially with your technique of posterolateral corner reconstruction. Thank you very much for the time. And thank you, Dr. Sundararajan and Dr. Bobby and Dr. Srinivas. I think we will call it a day here.